Hi, everybody. Welcome. Hopefully you can all hear me okay. My name is Eugenie Hsu. I'm on the board of the Raymond A. Wood Foundation, as most of you probably know. And I'm happy to introduce two neuropsychologists, doctors Gina Pfeifle and Shannon Lundy. They're both from UCSF, and they're going to be speaking with you about the application of neuropsychology in this brain tumor population. Sorry, that's not the official title of your talk, but I think that's roughly what you're talking about. And so they're going to speak for about 30 minutes. And then after that, there'll be a 15-minute Q&A. We do have a chat feature in the Zoom, so you're probably familiar with how that works. So if you think of a question, feel free to just put it in the chat, and then I will be fielding the questions at the end of their presentation. And all of you already know to mute yourselves, so thank you so much. And when we are done, I'll let you guys unmute as you ask your questions, or I can ask on your behalf. All right, so thanks, and why don't you guys take it away?
Okay. Hi, everyone. Thank you so much for having us here today. We appreciate you joining us on a Saturday, be it in the morning or afternoon or evening, wherever you are joining in from. So today, my colleague, Dr. Pfeifle, and I are going to talk about neuropsychology's role in the management of pediatric brain tumors. We are going to, we have some objectives to cover. So I'll start off with a review of late effects of treatment for pediatric brain tumor patients, both from a neurocognitive perspective, but also psychosocially. And I'll also review referral timelines and recommendations. And then Dr. Pfeifle will provide an overview about what pediatric neuropsychological evaluation actually is, including the utility of this type of assessment, and then she will discuss overall management guidelines. So when we start to think about late effects, first of all, what are late effects? And there are issues that arise following a medical condition that lead to complications, disability, and possible adverse outcomes. They can be something that happen immediately, but they can occur months to years following the completion of treatment. They can be physical in nature, so cardiac and endocrine dysfunction, gross and fine motor problems. They can involve sensory issues, visual field cuts, and hearing loss. They can also be neurocognitive, developing, and psychosocial, so involving social, emotional, behavioral type things. They develop over time as a result of childhood cancer and its treatment. And they emerge over time in development of the child because children are expected over time to master increasingly complex tasks. And when you just look kind of briefly in terms of the pediatric oncology patient population, we do know that late effects are a real thing. 2 out of 3 survivors will experience at least one late effect. 4 out of 10 will experience multiple late effects, and 1 out of 4 survivors will experience pretty significant severe late effects. Late effects are most prevalent in CNS-directed therapies. And unfortunately, at this point in time, the mechanisms of neurocognitive effects and why they happen to certain patients so significantly and others not are not really that well understood yet. So we can't really reliably predict in advance which patients are going to develop long-lasting cognitive late effects and which ones will not. So here's a nice developmental model when you're thinking about the various factors that play a role in neurocognitive late effects. Obviously, the child, you need to look at the genetics of the diagnosis itself, if it's the tumor type, if it's high risk, low risk, things like that. Obviously, it's important for treatment planning and things like that. The age, gender, and then any premorbid factors or family history of premorbid factors, if the child had ADHD or dyslexia or other issues beforehand, or if there's a family history of significance of those things, or anxiety and depression. And then when you want to look more specifically at actually the CNS injury that may happen, the direct injury that could happen, that factors that play a role in that are the tumor location and size. If there's hydrocephalus in and of itself can have a sequelae of cognitive and psychological factors associated with it. If surgery is required, and then from that, if there are surgical complications that arise. Treatment itself, does the treatment require radiation? Does it require chemotherapy? If so, what type of chemotherapy? What is the administration route going to be like? And then there are going to be various medical complications associated with the treatment course itself. And then all just the different associated issues when you're looking at the child's life environment and child world context that play a role. There's obviously a tremendous amount of psychological, emotional adjustment that happens when something like this occurs. There's a lot of stress on family systems when something like this occurs. For children who are school age, there's a lot of schooling, lots of periods of critical time in terms of interacting with friends from a social experience, and all those factors play a role in the overall outcome. And development in general is a very dynamic process. And so in the brain, what changes with development, new systems are coming online all the time. There is increasing sophistication of brain systems and more interaction between them. Systems that support a skill at one age may not be the same at a later age. An additional change is created by the fact that the child has become sick in this whole process. When that happens and what that looks like for overall outcome really matters. If the child requires surgery, there are definitely neurosurgical challenges that can arise. Sometimes complete resections are not feasible. There is going to require multiple resections. And from those types of things, various neurological and sensory deficits can arise. When you're looking at other treatment things, if you're going to need to have cranial radiation therapy, there are various challenges that arise from that. Rapidly developing systems are certainly more vulnerable during critical periods of development. We know that reading a young brain really impacts development and takes the child longer to meet appropriate developmental stages going forward. The younger child is more at risk for these types of things and more at risk for overall reduction in the amount and volume of white matter. And these brain changes impact learning over time inevitably as things don't get easier from a cognitive perspective, they get harder. And we do know that radiation damages white matter tracts, and it also can damage the hippocampus, which is really responsible for how we learn new information and store memories and things like that. From a neurocognitive perspective, the literature tells us that cranial radiation really has kind of a four different things involved from long-term outcome perspective. There's a kind of triad of symptoms: processing speed, attention, and working memory. But inevitably over time, then IQ also is impacted. That core set of processes ends up impacting overall IQ just because things get more challenging, as we just talked about, and leads to slower learning and meeting academic potentially demands over time and cognitive demands over time. Proton beam radiation therapy is a promising advancement for certain types of tumors. Radiation is focused into the tumor itself. Therefore, therapy is more sparing in terms of surrounding tissues and white matter in general. And there's a big hypothesis that this will limit the neurocognitive impacts. At this point, those long-term outcomes aren't totally well understood, but I think there's early evidence that's quite promising, and certainly, which is fortunate for pituitary brain tumors, radiotherapy technological advances in the last couple of decades have allowed the reduction of dose to uninvolved brain areas while maintaining an effective therapeutic dose to treat the tumor. And so this includes both proton beam radiotherapy and gamma knife. And the principal aim of pituitary radiotherapy techniques has always been to deliver just the right effective dose amount, targeting the tumor and the tumor volume, and therefore minimizing the radiation dose delivered to surrounding normal tissues, and obviously then reducing the overall risk of damage to the brain in general. From a chemotherapy perspective, certainly there are physical side effects related to that treatment as well. Certain chemotherapy agents may lead to cognitive issues due to the potential impact on white matter. The main risks for neurotoxicity include high dose treatment, intrathecal treatment, and younger ages. Certainly less commonly used for pituitary tumors, but chemotherapy may be a component of treatment for a subset of patients. Intrathecal chemotherapy in particular, which is the common route for brain tumors because it crosses the blood-brain barrier and allows to get into the central nervous system to impact the disease. And that is what is known to cause those cognitive impact, negative issues. And there are certainly physical impacts from chemotherapy, depending on the agents that are used. Some of the typical ones are ototoxicity, so hearing loss and or peripheral neuropathy. And in the literature, we know from chemotherapy, there are long-term neurocognitive effects too. Again, that core set of processes, attention, working memory, and processing speed is impacted, as well as motor speed, visual motor integration, and some math challenges. And we have this slide here, which is a little bit of a graph that kind of looks at the neurocognitive findings from the pediatric oncology patient population when they come to see us for neuropsychological evaluations, and kind of what the most common presenting issues are. It's increased academic trouble, attention problems, slower working speed, thinking speed, getting things out can be more challenging. And over time, these core deficits may lead to gradual declines in global intellectual function and academic achievement, thus the late effects that we are talking about. And as is displayed in this graph here, these are not necessarily declines in functioning, but rather a slower rate of development that leads to a widening gap between these children and their peers over time, which therefore can result in a drop in IQ, because this is a norm reference standardized score. So this, I think, just helps kind of see what the presentation can look like from a long-term developmental perspective. And kind of switching from neurocognitive to now psychosocial impact, there are lots of common emotions and feelings experienced for pediatric oncology patients in general, and certainly pediatric brain tumor patients. Anxiety, depression, anger, fear, isolation, trauma, all of those are very, very common. And other social and emotional concerns related to treatment can be just because of physical challenges. They don't look the same. They're not able to do the same types of things they were once able to with peers. That can really lead to self-esteem issues, social struggles, how peers react to them. The fact that they've missed out on critical periods of peer development and social development makes it just that much more challenging to ever kind of get back in and feel connected to their peer group. And then there can be adaptive behavior concerns, both from a conceptual, practical, and social perspective. So in terms of what we do about this, there are some kind of guidelines in terms of when to refer for these types of evaluations so that support and recommendations can be put in place. The Children's Oncology Group actually has some very nice guidelines that everybody, I think, does try to follow. Overall recommendations for assessment are baseline, pre-treatment, and then regular evaluations every few years across development. But notably, baseline evaluations are rarely possible in brain tumor patients. Typically, children are moving very quickly from diagnosis to treatment. They are already very sick by the time that the diagnosis is made. So there's never really a true baseline. And so that's, I think, a very hard thing to capture. But the Children's Oncology Group has now a standardized assessment battery, and that is what is used for tracking neurocognitive data over time in oncology patients. Certainly from a clinical perspective, it's really kind of a nice screen, and we use that, but then really depending on the presenting concern and the challenges that the child is having, or the parents are concerned about, or the school is concerned about, we really fill that evaluation to make it more meaningful and pertinent to the child. But the Children's Oncology Group, also, it's called ALTI, and it's a screening battery. And there are very standardized time points: 9 months, 30 months, and 60 months. So like kind of 6 to 12 months post-treatment, there's like always a 3-month window back and forth between those time points, 2.5 years, and then 5 years. And then I think clinicians choose, if it's younger children and they're more concerned about the online skills of reading and or math or something like that, they may choose to see them at even shorter intervals depending on age and what the presenting issues are. And really, essentially in any pediatric oncology patient, there should be a high suspicion of late effects of treatment for any cognitive challenges that you are noticing. Things like increased difficulties with academics, attention, executive function, processing speed, fine motor stuff, memory. Keep in mind that all of these kinds of cognitive issues become more prominent over time and in the years following treatment. And, as we talked about too, the psychosocial factors in terms of emotional dysregulation, behavioral dysregulation, anxiety, peer difficulties, those things are very common too. And so when and if these things arise, please know that, an evaluation can be very helpful and beneficial in kind of putting you on the right treatment course. And now Dr. Pfeifle will talk about what that whole neuropsychological evaluation process is, what it does, what recommendations look like, and how it can really be helpful.
Hi, everyone. Happy to be here with you this morning. So pediatric neuropsychology, just as a really brief overview, is a specialty within clinical psychology that's most concerned with the way the brain impacts behavior. Accepted training standards for specialization in pediatric neuropsychology include specific graduate coursework and clinical training in neuroanatomy, medical disorders, and psychology, including both a predoctoral internship and 2-year postdoctoral fellowship in pediatric neuropsychology specifically. And the utility of pediatric neuropsychology evaluations within the medical setting include things like helping the medical team to clarify developmental or psychological diagnoses in the context of the kid's underlying medical disorder, helping family members and medical teams develop a better understanding of who the child is in the context of their specific situation. So their specific medical disorder, the family context, and the family's cultural background. And importantly, to help guide interventions that will help support the child. So those can be cognitive, academic, or psychosocial in nature, and they can be interventions that are designed to be at home or at school. So it just really depends on what you find. And the goal of a neuropsychological evaluation is to tell a story of who the child is and to help foster an understanding of their needs. So, how do we do this? First, we typically obtain a comprehensive review of patient history, including an integrated presentation of family, medical, developmental, social, emotional, and educational history. And then we evaluate the overall cognitive profile of the child, looking at a variety of domains and highlighting their specific patterns of strengths and weaknesses. And then clinical analysis is then conducted based on the collected data and the history in the context of that relevant medical diagnosis. When did it happen in development? What was affected? What was the treatment course? And how does that now play a role in who the child is? And finally, then we make the appropriate recommendations and interventions tailored for the patient. So this includes services and supports across the settings like we discussed. So the testing itself is just one piece, and the assessment is really this overall process of clinical management. So we'll look at each of these steps in a little bit of depth. So first we have data collection, which is a multi-step process that includes history gathered in the parent intake, observation of the child during testing, and direct test results or scores from the evaluation. So in the history, the goals are to determine what the child is bringing to the table. What have they been exposed to thus far? What are their potential biological risk factors? So, a family history of reading problems, for example, or attention difficulties. Has a child been able to take advantage of the learning exposure they've had so far? And what has their development looked like to date? So were they delayed in their development, before getting diagnosed, or was their development typical prior to that? And then observations are a large part of our clinical work in the room with a child beyond the direct test administration. So within the test environment, we're looking at how do they interact in this structured setting? How well do they engage with us? What's their activity level? How social are they? And importantly, what is their behavior and problem-solving style under specific performance demands? And then the next step in data collection, which is actually happening at the same time as a lot of our observational data, is the testing itself. So a neuropsychological evaluation assesses the child's functioning across many domains, things like overall IQ, attention and executive functioning, language ability, visual processing, fine motor functioning, memory, psychosocial functioning, and adaptive abilities. The specific concerns raised by the parents and the treatment team, as well as the known cognitive risk factors of the kid's medical condition, really helps to guide how much testing is done in each area. So for example, you would do more testing of language in a child with a history of language delay than you would in a child without that. It's important to note that we do not typically assess much academic achievement for a few reasons. First and foremost, issues with academic achievement can and should be assessed within the school setting. Because of this, it's not typically possible to get insurance coverage for academic specific testing. And then as neuropsychologists, we're really more concerned with the underlying cognitive weaknesses that cause academic achievement issues than the specific academic deficits that may be found. So within this context, we'll sometimes include targeted assessment of specific academic issues when they're relevant to the child's medical disorder. So a lot of times we'll evaluate reading in a child who was diagnosed with cancer early in their school career and who missed a lot of that early reading instruction due to school absences. So moving on to test interpretation, when you're looking at the child's score tables, I think even as parents or teachers, you can pretty easily pick out what domain the test was looking at and how well the child did compared to age expectations. So were they, performing sort of averagely or above average or below average? But that alone can be misleading. So many tests can be impacted by multiple cognitive or behavioral factors. So like a one size fits all interpretation can be incorrect for an individual patient. So in general, the tests rarely assess one domain cleanly. Many tests require multiple sensory systems like visual, motor, auditory processing, and deficits in one domain may impact performance on a test designed to assess another domain. So an example of this is kids with weaknesses in attention or executive functioning often have variable performance on memory and learning and memory tasks, but we would not then say that they have a memory deficit if the reason why they can't remember the story is because they weren't paying attention in the first place. Overall, this is why it's important to have a comprehensive battery that assesses these domains from multiple angles, so you're not basing interpretation on a single subtest or observation of behavior. And then we also are looking at, after we take these test-specific factors into account, we're looking at what are the patient-specific considerations that also impact a kid's performance. So things like their age, their language history, their cultural background, their physical and sensory abilities. So in summary, the tests are necessary for our case conceptualization, but not sufficient with all the additional information, without all the additional information. So clinical analysis is the consolidation of all that data you've collected in the context of the individual family and patient that you're working with. So it's where you synthesize that overall test data with relevant history and clinical presentation. And it's really here that we're determining the child's strengths and weaknesses, both within their own profile and compared to their same aged peers. And then we use this information to determine their pattern of performance as well as their overall developmental trajectory. And following clinical analysis, we can then make diagnoses if those are applicable. And then the final step in the evaluation process is the management. So first, we need to consider how is this child's profile presenting? In other words, how does it impact their daily functioning? So two children can have the same profile, but present quite differently in how their strengths and their weaknesses manifest and how pervasive those weaknesses are. So therefore, the management approach may be different. And then what are the risks for a given child based on their specific history and presentation? And we want to think about all aspects of risk here. So cognitive risk, academic risk, social risk, emotional risk, as well as both, what are we concerned about short term, and then what are we concerned about more long term? And then we develop recommendations to address and support these areas. And, really the goal that we have is to, end up with a comfortable, competent child and adolescent who's moving into adulthood in a way that's going to be, as beneficial as possible. So when we talk about comfort, we're thinking like their emotional status and their social competence. And then, competent, we're thinking about their adaptive functioning and their academic and vocational achievement and all those things that we want to keep in mind as we're addressing them when they're younger. And then the recommendations really need to be tailored to the individual patient and their home life, so you want to consider, how much time are these recommendations going to take? And if there's a lot of things that you think the kid might need, and we know all families have so much going on, if you want to help the families kind of figure out for their priorities, what recommendation might be the best one to start with. And, just keeping, in mind that, in an ideal world, we would do maybe a lot of things, but, that's not always the realistic goal. And so what's most concerning for the family at this time, and then helping them to figure out what recommendations or interventions are going to be the most beneficial for that thing that's the most prominent or concerning. The information gathered during the evaluation, the diagnosis being made, and the recommendations being provided are then communicated through a variety of means. So we'll do a feedback with parents, which is done face-to-face or telehealth. And this is really crucial to communicate, what did we find and what the recommendations are, and to have that discussion over what we want to sort of focus on. And these appointments also allow for questions and interactive discussion. The report documents sort of what, how, why, and what to do next, and can be helpful for parents and schools and medical team members. And then sometimes we would participate in school meetings, and these are really more interactive and help to integrate the findings or recommendations into special education plans, and to provide additional information or psychoeducation regarding the child's medical history to the school team. Now that we've reviewed what a neuropsychological evaluation entails, we'll discuss overall referral, sort of like management guidelines for patients. So a big component of support for families is actually around things like what can you get from school? What are your rights at school? How do you request a school-based evaluation as needed? It's also about providing referrals for individual or family therapy, discussing sometimes potential medication management of things like attentional concerns. So just talking over what that typically looks like. How does that process work? Who would you work with for that? Because it's not us. And then also just general health guidelines. So support for overall health, guidance regarding, things like benefits of nutrition, exercise, sleep, those sorts of things. And then there are some treatment options available for cognitive late effects, including, and we'll kind of briefly review these and talk a little bit about some of the benefits and challenges associated with each. So cognitive remediation programs generally look at one skill or a small subset of skills, like maybe up to 5. And these are typically multidisciplinary programs that include support from school, rehab, clinical psychology, and they tend to be intensive, individualized, and expensive. So there aren't a lot of programs like this available nationwide, actually, because of all the time and effort that they entail. And then, sort of a subset of these are, more of like a cognitive computerized training program. So things you might have heard of like CogState or CogMed or Lumosity. And these programs generally consist of repetitive and task-specific training with increased difficulty over time. There are lots of concerns, sort of from the professional side about a lot of these programs, about sort of their generalizability to like day-to-day life. And like, can you take it from that task-specific practice into something that you're actually doing at home or school? And the ones with sort of the best documented outcomes do also typically include individual coaching and support. So not something that you're going to do just on the computer and have the same sort of outcome as if you have someone sort of helping to support at the same time. Pharmacological treatment consists of a few different strategies. So there are stimulants for attention concerns in the cancer population where attention has been a problem. We have found that, data has shown that stimulants are typically less effective in the brain tumor population. So this tends to be something that is recommended more often for childhood leukemia. There are other drugs that are, have shown some benefit for fatigue or some preliminary cognitive effects, but really a lot of these are just like very, very early stages, really looking at clinical trials primarily at this point. And then, finally, exercise has actually shown some really nice, well-established medical effects with no adverse concerns and a lot of positives. So some of the less appreciated cognitive benefits of regular exercise can include learning and memory benefits, delayed age-related memory decline as kids get older and move into adulthood, and then also mood enhancement, which I think a lot of people are fairly familiar with. So that is really what we wanted to cover today. So I will stop sharing and I think we can move to the Q&A section.
Hi, thank you so much for the presentations. Appreciate that. We now, just to let you know, we have, let's see, 19 people with us today. And we do have a few questions. So I'm going to ask you the questions. And if for whatever reason I don't ask it in the exact way you intended, please feel free to unmute yourself and add to the question or follow up with a question if you need more details. Okay, so I'm going to put them in the order that I saw them in the chat. So the first question is in regards to slowed processing speed. The question is there anything that the patient can do to improve the processing speed, or at least keep the processing speed from getting worse or slower? First question.
I don't think there's actually anything that can be done about it per se. But I think there are various compensatory strategies that can be put in place to help support it. So I think it also depends on the age of the child, but things like extended time to complete tasks, less information at once to allow for that. I think from an academic perspective, if you're doing a worksheet that has 20 problems and the child understands it, then they do 10, so that that system doesn't get overloaded by too much information. I think as one gets older, just allowing for more time for some of those things because they know it's going to take more time. Those are things that can be beneficial. But in general, from the research and from my own clinical experience, processing speed is about output. It doesn't really get faster per se, but I think that there are just ways to work around it and things to kind of accommodate it. I don't know.
I think one of the only other things I would say is like, something that we sometimes recommend for kids with slow processing speed, like at home, are things like setting up really consistent structure and routines, like at morning or at night, because having things be really similar every day can also help support some of the like speed with which they can get through those sorts of daily activities. But yeah, as far as cognitive and academic, I think Dr. Lundy covered it.
And I think to that point, like the automation of tasks so that things just become more fluid, that can be really helpful. And so how to set that system up, depending on the age of the child, they may have some insight into that too. And so but younger kids, they won't. And so I think you work with school teams, you work with parents, you kind of develop something that makes sense around the issues that are important. And then obviously let some of those things go. So you just know it's going to take a little bit longer. So.
Okay. Also, just to remind you too, there may be people in this group who are parents as well as adult survivors. So there are some people, I believe the person who asked that question was an adult survivor.
Okay.
Just FYI. But thanks for the answer. So one of the questions that I had actually that other people echoed they were interested in is one of the charts that you showed compared typical non-tumor patients to brain tumor patients. And you indicated that the problems seem to become more prominent over time. So one of the questions was, why do they become prominent over time? Is it in comparison to typically developing children, or do the problems actually become worse over time? Can you just answer that, please?
I think there's two answers to that. I mean, I think that, yes, when you look at that slide, it's compared to typically developing peers. So yes. But in life, things don't get easier from a cognitive perspective. The demands cognitively become more complex. So what is expected of a child at 8 or 9 is very different than 15 or 16. And college, being independent, being able to juggle multiple types of things at one time, all kids have a normal developmental curve and having to learn that. But children who experience what pediatric brain tumor patients can experience are potentially more susceptible to really not being able to meet those new challenges. And so this idea that, oh, the brain is developing and it's going to all get better over time is really not true. Because if you have a healthy brain that has an acquired injury that is significantly impacted during development, that brain doesn't go back to being normal again. It is now altered and changed. And so development is changed. And so the efficiency and the effectiveness with which those white matter systems are able to communicate and work have had to be reworked and rewired. And yes, kids can develop compensatory strategies and learn different things. And so some kids can do well. And if we knew which kids were going to be more at risk neurocognitively and which ones weren't, we would be able to intervene sooner, but we don't know that, unfortunately, yet. So when we're talking about this, this is what the literature shows us in brain tumor patients. Obviously, certain types of patients, as we discussed, those who are getting radiation therapy, be that cranial, not necessarily proton, kids who are just getting chemotherapy are potentially less at risk for some of these problems. Kids who just have a surgical resection and don't have any complications from that and don't have any hydrocephalus are potentially, yes, less at risk. But when you're still looking at the overall picture, these are just generally speaking in the pediatric brain tumor patient population, things that kids can struggle with. And one kid who has the same type of tumor as another kid can actually have very different developmental outcomes.
Thank you. Did you have answer that question, Dr. Pfeifle, or no?
Shannon, that was great. Yeah, no,
Okay.
same thing.
Did that answer the question? I mean, we're happy to
Yeah, I
say
think it
more.
answers the question. And I think that there was a comment in here from someone that said, I've always been told that things would improve with the time as the brain heals. And maybe there's some, thinking of neuroplasticity here.
Yeah, I mean, there's some aspects to that are true, right? When your kid is going through active treatment and there's lots of physical fatigue and physical side effects of medication and things like that, and you move out of that active treatment into recovery, you are going to see some changes and benefits from not being in the active treatment period. But when we think about I think attention is a really nice example here. A child who, has treatment that impacts their attentional capacity and they're young, you might not notice a big difference between them and a child their age who hasn't gone through treatment. But then over time, you're going to start to see those attention challenges more clearly as the expectations for attentional capacity increase in their day-to-day environment, and they're not able to meet those expectations. So just like Dr. Lundy was sharing before.
Yeah.
So I think, there are ways in which you can see improvement over time in, what's going on for that child. But if there's been a neurocognitive insult from the treatment, we don't expect that to totally clear up and just get better and it goes back to what it was like before.
Right. I think the one thing that might be a question here, and this wasn't posed in the chat box per se, but I think one thing I'm thinking of is, typically developing children, they haven't reached full maturity at age 5 or 7 or 10. Their brains are developing into their 20s. So would that be consistent with a brain injured child? Like, would their brains also be maturing so that, by the time they're 25, even with a brain tumor injury, do you expect to see them mature as well in the same way that a typical kid would? Does that make sense?
Yeah. Let me see if I can pull up that little graph we made.
And I'm using the word mature in a very generic way,
yeah.
It's sort of like,
you're right. I mean, I think the literature actually at this point probably shows that female developing brains from a development really see active development go up through about age 19. And then for young males, it's about 23, but it's not beyond that. And it actually really, there is a difference gender-wise between males and females. And certainly adolescence is the second biggest time of development in terms of a lot of those projections and connections from the cerebellum to what that frontal lobe system and that higher order executive function system becomes are happening. So certainly there is development that can happen, definitely, and rewiring and reworking. But it's not the same. It doesn't go back to being what it was before. And it's not that's not what anything really shows us from a literature perspective in terms of things just catching back up totally to be normal. Now, of course, there are going to be some patients and some kiddos who don't have, we're talking about what can happen. We don't know who does and who doesn't have these issues. We can't predict that. So not every single kid is necessarily going to have these troubles, but some will. And so I think it's just preparing for the ones who do struggle.
Okay.
And I think part of it too is just because some of this stuff shows up late, it's just being aware that it can be a complication that arises, so that if you're 5 years down the road and things, they've moved in, let's just say it's a kid, it's 5 years post-treatment and your kid is now in high school and suddenly they're having trouble keeping up with all the different, where are the different classes and what's due when and things like that, you can sometimes not appreciate some of the challenges that might be arising from the treatment until they're older, because it's at the point that suddenly these systems are being taxed at a higher level that you start to see some of the challenges. And so that's also some of what we're trying to communicate, I think. And then this is that graph that we showed before. And so really what we're trying to get out here is there is this period, right, where everybody's just progressing along, and then there's some sort of insult, whether it be treatment or because we see this also with brain injuries or other kids with other medical conditions. But over time, then they're continuing to to grow and make gains and learn new things, but it's just that the pace of that is slower. And so that's why you can start to see that bigger difference over time. I hope that's.
Yeah, thank
It
you.
doesn't happen to all patients. And I think the whole reason why you want these assessments and evaluations is that there are definitely compensatory strategies that children can internalize and develop, and with supports can help make those developmental gains better over time. But you
Okay.
can't do that if you haven't identified what the issues are and you haven't put any supports in place.
All right, thanks. We have a few more questions, so let me just get through them here. One question has to do with at what age do you typically do a neuropsych evaluation? In this case, it's a parent of a child who was diagnosed with a brain tumor at 2.5 years old, and the kid is now 6, and was told that that was still too young to do a neuropsych evaluation. So what age do you recommend? What's the protocol?
I mean, to be honest, like I would say around now would be when I would do a first evaluation. So typically as they're entering school is like a time for like the kids that were diagnosed really young as babies. We like to try and see them as they're entering school to make sure that if there's any like areas that we're seeing already, that we're making sure, things are set into place for them right away.
I would say from like an instrument perspective, I mean, there's some validity for what this person was saying, that it was too young, because things like memory from a cognitive perspective, really, there's not formal measures to assess memory because kids are about 5 years old. That's the same thing with like attentional capacities and certain types of very basic executive function stuff. We don't really start to test that. You can in younger kids, but doesn't really kind of start to come online in a more meaningful, complex way until 9 or 10, 8, those things happen. But there are certainly developmental things from a developmental perspective. When we talk about neuropsychology, when kids are younger, there are definitely still some developmental measures at 2.5 or 3 for kids who are already developmentally delayed and showing problems that definitely pick up on those kinds of things. And so I would not say that, it's not a true neuropsych eval, but you should definitely have had a developmental assessment to ensure that speech and language, occupational therapy, physical therapy, and or preschool supports can be put in place.
Thank you. Next question is, has there been any benefit to using Ritalin for brain tumor patients? And that, because that's something that's been mentioned, and you did mention stimulants in your talk.
And as Dr. Pfeifle said, I think the literature is much better for the pediatric oncology ALL population and it is in the pediatric brain tumor population. There's just not tons of research yet to show that it's as impactful and or as helpful. That isn't to say that for some kids it hasn't been helpful. I think it really just depends. I mean, but when you look at the literature, it's much more consistently been positive in the broader oncology population and not necessarily the brain tumor population, but certainly totally some families have found that it can be really beneficial.
Yeah, I mean, I think that's like, this is a great place to talk about the difference between like what we know as a broad group versus like what we know for an individual patient, right? So for individual patients, like you have to treat what you're seeing, right? So if there's a lot of attention problems and, that's something that's getting in the way of their learning, trialing attention medication is certainly something that on an individual case-by-case basis you would want to do, because if it does help, then it helps, so these are sort of like the broad understandings that we have, but that doesn't mean that on a case-by-case basis you wouldn't try things.
Mm-hmm. Okay. Let's see. Another question has to do with, I'm going to just kind of jump around to make sure different people get to have their questions answered. Here's a question about emotional regulation issues after resection. Is this a typical problem that you see after frontal lobe damage? And then I have a follow-up question to that, which is when you see a frontal lobe damage and the impact on executive functioning or emotional regulation issues, do you know if there's any literature that shows that some of the evidence-based treatment practices, such as dialectical behavioral therapy, can have any impact on a brain injured patient? So that's sort of two questions.
So certainly with frontal lobe damage, you can see emotional dysregulation. That is very common.
And I would say behavioral too. I think kind of both those types of things are intertwined.
Correct. Yes. As far as what to do about it, we often I done a lot of work with brain injury in my training. And one of the things that we find is that a lot of the tools or behavioral management techniques that you would put into place for a kid with behavioral challenges of any kind work, but oftentimes you have to sort of change what you're intervening on. So instead of doing, the behavior happens and there's a consequence, it's trying to find out, like, when is this behavior occurring? Is it always occurring in these specific settings or with these specific triggers? And then trying to intervene on those antecedents, so the things happening before the behavior occurs, and trying to set up the environment to make the behavior less likely to occur. Because it can be a situation when you've had a brain injury that's impacted your frontal lobe that you are going to be less able to learn from sort of like consequences. And so because there's this aspect of impulsivity that's driving some of that behavior challenge, and that's something that they can't necessarily control. And so it's about sort of setting up positive sort of environments and routines that are going to make that behavior less likely.
Okay.
Into your question about DBT, CBT, those kinds of treatments, I think it's in the brain tumor patient population, not brain tumor. I think it's more in the brain injury population. There's a little bit more literature, and I think there's some patients really do benefit from, and some don't. I think that, again, there's some literature that shows that it's helpful, and those would definitely be the types of therapies to use. And some people can find it really helpful, and then some people feel like it's just really challenging. So for some kiddos, for example, who have a lot of issues with memory and they can't really remember week to week what they're practicing and working on, that becomes hard. But for other kids who don't have those issues, it can be very effective.
Yeah, thank you. I'm aware of the time. I believe we are supposed to be stopping now because it was only a 45-minute period. And there's a few more questions. Some of them are just very, simple questions, such as, do neuropsychologists prescribe? And I think the answer is no.
Yeah, I'm looking through the things too. We don't, because we're psychologists, we're clinical psychologists. So psychiatrists and or pediatric neurologists and or even a pediatrician would be who would prescribe this type of nuanced medication. I would recommend probably child and adolescent psychiatry and or a pediatric neurologist who does a lot of work with children who have different kinds of issues, just because the nuances from a pharmacological perspective are important and meaningful. And so those would be the types of people that I would recommend. I see that there was a question about growth hormone replacement and cognitive functioning. There's not tons of literature on that. If there is, I'm not aware of like a huge article on that. There's directly related to cognition, no. But obviously it's a side effect certainly for most pediatric brain tumor patients. And then the question about developmental assessment for younger age kids. Yes, there's different instruments used, the WIPSI, the Bailey, the Mullen. It kind of depends on the age of the child and how much language they have and the comfort of the clinician, things like that.